welcome to everyone who's joined in. Thanks for logging in to our careers webinar. So hopefully we can give you all of the information that you'd like and require if you're considering an application to medical oncology. We've got a few people here today that are going to talk, so I'll allow them to introduce themselves. So firstly, my name is Richard Heywood. I'm a medical oncology registrar in Leeds, and I'm currently the chair of the ACP Registrars Committee. I've got Dr. Simon Pacey. If you'd like to introduce yourself, Simon.
Thanks, Richard. So I'm a medical oncologist, the phase 1 team in Cambridge. I'm the clinical lead for national recruitment and our academic training lead for our training committee.
Thanks. And we've got Dr. Satinder Jagdev.
Hi there, my name's Satinder Jagdev. I am a medical oncologist from Leeds with an interest in neurological cancers, and I also chair our Specialty Advisory Committee for Medical Oncology at the Royal College of Physicians.
Thank you. And Dr. Pickrell-Smith, Ben Pickrell-Smith.
Hi, I'm Ben. I'm a medical oncology registrar, again in Leeds, sadly. It's a little bit Leeds-centric today, but it's nice to be here. Thank you.
And then I've got Dr. Louise Hanna.
Hi, I'm Louise Hanna. So I'm a consultant clinical oncologist based in Cardiff, and I'm also the medical director for education and training for clinical oncology in the Royal College of Radiologists. So I'll be available to answer any questions about clinical oncology that you might have.
Perfect, thank you. And then Dr. David Johnston.
Hello there, I'm David Johnson. So I am a clinical oncology registrar doctor, and I co-chair our registrar doctor group. So nice to be here.
Brilliant, thanks. And then we've got Alison Norton, who is, I don't know if she's introduced her, but she's our sort of secretary at the ACP and does lots of work for us. So I think without further ado, I think we'll start with the talks. And I think first up is Simon Pacey, who's going to take us through the application process. So I know that lots of people pre-submitted questions, and hopefully the talks we're going to have today will answer most of those questions, but we will have a Q&A at the end. The Zoom settings are automatically set for people to be muted. So if you would like to ask a question during the chat, please just send a message through the chat to everybody, and we'll pick up on that either during the talks or more likely at the end. So we won't ignore it. So Simon, I'll hand over to you.
Brilliant. Thanks, Richard. So we can probably go on to the next slide if you wouldn't mind. But welcome everyone. Thank you for joining our webinar. We've run a few of these now. So we're actually, as you can see, we've got a good sized panel covering a variety of expertise. So we're excited to have a chance to chat with you about career in medical oncology. And hopefully between us over the next 30 to 40 minutes, we can give you a flavour of our different roles and what's so appealing about a career in medical oncology. And as you've hopefully picked up from the introductions, we're also really lucky to be joined by Louise and David. Ruth may be able to join, who's my counterpart, clinical lead from our closely related specialty of clinical oncology, because we quite often get questions related to careers in oncology. And so we're happy that we can share that panel discussion as necessary. So delighted they can spend the evening with us as well. So thanks guys for joining. You can see the brief agenda there. As Richard said, I'm going to kick off with just some brief thoughts on the process. We're going to have a couple of talks from Richard and Ben on life as a medical oncology registrar and their perspectives. It's probably the key talk for the evening. And then Satinder will give you a flavour of life as a consultant and what your career might turn into in a few years' time. As I say, leaving plenty of time for questions and answers, and do put them in the chat. We've got some pre-submitted ones, so thank you for those. And we'll try and cover as many as we can. This will all be recorded, so you don't have to try and keep up with various dates. Some of these things you might want to come back to and look at later on. But I've put on this slide the key dates for our current application round. Medical oncology hasn't always participated in round 2, but we have grown significantly, and we feel that we do need to be running this second round, and that may well become far more common. So that's good news if you're thinking about joining us. We're looking at the adverts being published on the 28th of July. You can see the application window there running through to the 14th of August. The upload for evidence 15th to the 25th of August, with a provisional date for interviews, unlikely to change, but of the 13th of October, with first offers being released on the 21st of October. So that gives you a sense of the timelines, and I think the first post start date would be February, so the first Wednesday in February, which I think is the 4th of February 2026. But that we'll come back to later on. So the application is similar to other medical specialities, so I will go through this fairly fast. We're a Group 2 speciality, so that requires you've completed the first 2 years of IMT training program or equivalent. There is a lot of information on the PRSO or the PHST website, so please do look at those Am I Eligible sections for the sort of intricate details of individual questions. There's a lot of information out there. You submit your application through Oriel, and you'll see the status changing and your updates through Oriel. If you've submitted your application, and I know some people this happens to, you don't get that confirmed, do contact the office admin team on the emails they're giving you the day after you submit. So it's a really good reason. Do not leave your application till the last minute, because you need to make sure that the information has gone through and been received. And then you'll be looked at in terms of long listing. Are you eligible to enter the next stage? If not, you'll have an email received an email explaining why, or the lead regions team might come back to you and ask for more information and give you a deadline to supply that information of things they wish to clarify on your application. So keep an eye out for those emails as well, and keep an eye on your junk folders and various things as always. It is all dealt with through those emails. There are no phone numbers, but the office team are really responsive. So yeah, as I say, just make sure you keep an eye on all your email inboxes through this time. Frustrating if you miss those requests. The 3 stages are probably very familiar. So there's the long listing stage we've slightly just talked about. Do you meet the eligibility for a higher speciality post? Shortlisting as such, we don't do. If the shortlisting is there if we haven't got sufficient capacity to interview all eligible candidates. However, we do now assess commitment to speciality before the self-assessment verification stage. So in keeping with a lot of your questions about how do you demonstrate commitment, it is an area that I think is worth focusing your attention on, about what you write and what information you give us. And then from there, you'll move on, if you're successful, to the interview stage, being assessed by consultant colleagues who are your interviewers. Will ask you questions around a variety of areas and assess your answers in a score system we'll go on to in a minute. The commitment to medical oncology is similar to other specialities in terms of the guidance from the PRSO, but essentially 2 assessors will give you a score out of 10, so potentially 20 marks. The range seems incredibly high in terms of you can go from 2 to a 10. It doesn't matter, especially in that the commitment score is not taken through to interview, because the commitment speciality is assessed at the interview. So I wouldn't lose too much sleep about whether you get a 2 or a 10. The key point here is you have to show a commitment to speciality. So the other key thing that people don't realize and comes up in the questions and worries people is the level at which you're being asked. So we take account of your stage of training. So there is a different account taken to someone who's had, say, 10 years working in various healthcare systems, who might have had a chance to work in hematology, oncology, do a fellowship, but hasn't got a training number, versus someone who is very committed to a career but hasn't had a chance to get a rotation in oncology. So do not be put off by that. You're both able to show very good commitment, and we can talk a little bit about that, and I think Ben and Richard will pick up on that. Next slide, please. The other scored areas in the application form and the scores they're marked out of are shown here. Again, rather than going through this individually, I think the best thing is to say, definitely look at the PHST website, look at the guidance, look at the most up-to-date advice for this round. It does change some rounds in advance, but this is the current scores. As you can see, different scores and weighting for different domains, MRCP scoring quite a lot of marks, as do publications. But those, and you add them up and you add the commitment to speciality, give you your overall pre-interview self-assessment score. Thank you. Next slide. Your assessed score has to be evidence, so you'll have a separate system from Oriel. You'll be given details of how to upload after your application form from the lead region, and you've got to give us sufficient evidence without overburdening us to justify the score that you've selected. And you need to tag that evidence to the relevant domain. So you're going to assess yourself against the scoring matrix, and then that score is verified by a senior clinician against the evidence that you've provided. So we can't infer, we have to go on what you're providing. So it is key that you give succinctly but adequate information. And worth also pointing out, scores, whilst you think we're marking them down, scores can also be increased. So those senior assessors will be looking to give you the correct score and give you as many marks as your application allows us to give you. Then that verified score goes on to make that proportion of the total score, which is then used later on in your ranking and offers if you get through the interview stage. The key things I keep coming back to, there is detailed guidance on the PHST website, and I really can't recommend strongly enough that you familiarise yourself with the guidance. It is relatively wordy at points, but the information is there. And key things, which is my second point here, where it suggests what preferred evidence might look like. So if you want to try and score the most marks for your audit quality improvement, then mirroring a quality improvement assessment form is probably the best and most recognisable form of evidence, in the similar way for a teaching observation form, which then might mean you don't have to provide any further evidence because it is all there in a fairly standardised method. If it's not available, if those forms are not available, then evidence will be specified on the website as examples of things you can give. Please do not forget to redact patient identifiable information. That does occasionally happen. And don't forget there's also a mark for being organised, which is 2 points. So it doesn't seem very many, but when everyone quite often is bunched up, a point here or there can actually make a difference to your ranking. Thank you. Next slide. Very briefly, in terms of the interview, I think others will comment on this, but I would suggest that to think quite strongly about getting some practice. I know interviews and the format is probably familiar. We're all used to working on Teams now, but do have a think about getting practice from people who've been through it recently or colleagues at a sort of a slightly more senior level. Look out for your invitation and the booking emails, and think about that preparation, not just the practice of the interview and the aspects of the learning, but your technical setup, how your camera's set in your room, that you're set up, you're distraction free, and you're trying to mirror a sort of an in-person interview virtually as much as you can. It comes across much better for the people who are interviewing you if you can demonstrate that engagement. The general format is that you'll have 2 panels, 2 interviewers per panel. There's 11 minutes for each of those panels. We have 4 scored questions marked from 1 to 5. First panel will be clinical and ethical, clinical, and then you'll have an ethical, professionalism and governance question. And then the second panel will cover suitability and commitment, and then a research academic question. So 6 minutes and 5 minutes for those, roughly. Thank you. Next slide. The scores are on the website, as I said, scored from 1 to 5, judged again, key point, against the level expected of a UK core trainee in CT2 for us. So we are not expecting detailed medical oncology expertise to score a 3. So do not be put off. You're meant to be entering a training program to learn about being an oncologist. So if you don't, do not be afraid you have to know everything about every type of treatment, chemotherapy, targeted therapy, etc. Total of 8 possible marks with a potential 5 from each interviewer, so it gives you a maximum raw score of 40. And the things that make you possibly appointable interview are just copied from the website. So I won't go over those in the interest of time. So next slide, please. The offers are made through on Oriel. Very simply, the highest scoring candidate gets the first offer, and second and third, and so on. Potential employers run pre-employment checks. The posts start on that first Wednesday in February, but it is often possible to negotiate different start dates, so you can contact the region, which comes down to that point in red below. There is a lot of information on the various websites about your application, preparing it, and what to do. If you are lucky enough to get to the point of getting an offer and it's a region, from a TPD point of view, we find out quite late who's coming. So that second bullet point, do not be shy to contact people in the region you're exploring, either ahead of interview for advice, e.g. your training program directors, current registrars. Medical oncologists are not yet in every hospital. So as you can see, we work closely with colleagues in clinical oncology. We're interested in people coming into oncology and looking after patients with cancer. So I'm sure an oncologist of any flavour would be happy to discuss careers in oncology in your hospital if you can contact them. But don't be shy about approaching people and asking for that advice. And remember that we are looking at that midpoint IMT by the time you get to interview. So that's a whistle-stop tour. If you do decide to go for it, good luck with the application. And I'm going to go on to the next slide, which I think is to remind me that now you're getting onto the more important bit of the talks, which is Richard and Ben giving you their perspectives as life as a medical oncology registrar and career journeys. So thank you, guys. Over to you.
Thanks, Simon. There's just one question that that's popped up in the chat that I think would be worth addressing now. So somebody's asked in terms of the scoring, if their scores were attained in, say, FY2, that can still be used for oncology. It's everything to date, isn't it, into your training?
Absolutely. Yeah, absolutely. There were some domains that had a sort of almost an expiry date, but it wouldn't be from FY2 to CMT. So it is through through your training. So it isn't reset. You have to just show what you did at CMT. So yeah, might be things at medical school, might be things during your foundation. All of those are relevant for the applications.
Brilliant. Thanks for clarifying. And there have been a couple of other questions that I think should be picked up in our talk, so we won't address them. Hopefully they'll be.
Thank you.
So thanks, Simon. So I'll talk next, and again, I'll hopefully kind of try and keep it fairly brief. So as I said at the beginning, my name's Richard Heywood. I'm an oncology SPR in Leeds and chair of the ACP Trainee Committee. So we thought it was just nice to show you how we got to where we are. And I think the key that we're trying to emphasize is that no two people are the same. So I, a long time ago, it seems like, started university and then went on to complete my training. I did do an intercalated PhD, but that's unusual. And in hindsight, I'm not sure is actually the best way to do things. I then went to Oxford to do my F1 and F2, did no academic jobs there. I then, like a lot of people, decided that I wanted to have a year abroad and do something different. So I went to Australia for a year. Spent my 30th birthday climbing the Sydney Harbour Bridge, so hopefully getting a bit of work-life balance there. Then I came back to Leeds, back to the UK to do my core medical training, as it was then, IMT now. In 2020, I applied to medical oncology for the first time, and due to various reasons, I was unsuccessful. So I think sometimes you're not successful, and one of the key things is about then what you do to sort of keep going if you're really interested. So I was lucky enough to get a clinical fellow job at the Christie, one of the big cancer hospitals in Manchester, and I thought that was incredibly valuable for me. I learned a lot from it, and it made me a better sort of candidate, and I think a better position to apply. And so in 2021 I applied again. Unfortunately, this time I was able to get a post, and I've continued that until now. And as of 3 years ago, I went less than full time, which is very much lots of oncology trainees do less than full time. So if you have any questions about that, I'd be happy to talk about that. And I spend a day a week with my 2 children. So again, I think it's really important as we go forward in our careers that we have that good work-life balance, and that's been really valuable for me to be able to spend some time with my children. And I did the ski exam in 2023, which, touch wood, is hopefully the last ever exam I have to do. So that's a nice feeling when you get past that. So just to talk a little bit about medical and clinical oncology, and I'm sure some people may know this already, and I'm sure some of you probably went to the RCR event a few weeks ago. But essentially, medical oncology is a group 2 specialty, as Simon mentioned, which means that you can apply to start at the end of your IMT 2 year. You can do IMT 3 and then apply, and some people would prefer that, some people don't, so that's a very personal choice, but you can apply at either point. You do have to have completed MRCP by the time of starting your training, which I think is a really important thing to think about, because you don't want to lose out on a place by not completing your exams. And as things stand at present, and hopefully for the near future, we're not dual training in internal medicine. On-call requirements do vary. Most places you do non-resident overnight on calls, but there are some places where where you are resident. So that's probably something you might want to look into if you're interested in a certain area. As of a few years ago, trainees entering ST3 in either medical or clinical oncology do what's called the Oncology Common STEM. So this is here, just ST3. And what that means is that you will do your training in tumour sites that have systemic therapy and some radiotherapy. It's all about developing generic skills. So as a medical oncologist, you're not expected to be able to plan or deliver radiotherapy. But it means that we get more exposure to planning radiotherapy and how you safely deliver it than our trainee counterparts in previous years. And to address one of the questions, what it does mean is at the end of ST3, you can apply to transfer from medical to clinical or clinical to medical oncology. It's not as simple as saying you want to switch. You do have to go through a national selection, but clearly if you've had a year of oncology training already, you'd be in hopefully a good position for that. And it does rely on your deanery or where you want to go having posts available. So you can switch, and if you switch at this point, your competencies are transferred so that you would start at ST4 from the other specialty. So that's one thing that has happened in the last few years. I will briefly just go through the differences, but I think it's worth pointing out that the differences actually are slightly dependent on where you work. And in some places, clinical oncologists do a lot more systemic treatment and some do very little. But essentially, the main difference is, so one is that we're run by different colleges. The duration of training is slightly shorter for medical oncology, and we have slightly fewer exams. Day to day, essentially, a clinical oncologist is trained to deliver radiotherapy and also can give systemic therapy alongside that, whereas medical oncologists focus purely on systemic treatment. And as a result of that, we would be more likely to manage patients in non-curative advanced settings, whereas clinical oncologists more often treat people in a curative pathway. But this is not cut and paste. There is a lot of overlap between the two specialties, and you'll find that in lots of centres they work very closely. And part of being a medical oncology trainee is learning how to deliver clinical trials and new systemic treatments. Lots of tumour sites have both, so things like lung cancer, breast cancer will have both medical and clinical oncologists working together. There are some tumours that I've listed here which are almost usually delivered by one or the other, but again, there are people across the country that do these tumour types from both specialties. This is just a slide looking at some of the parts of the curriculum. So up on the top right here is some of the areas that are shared between clinical oncology and medical oncology. And then down here is some of the slight differences. You can see there is a bit more here in clinical oncology about radiotherapy, and this is about clinical trials, managing intensive systemic anti-cancer therapy. So there are differences between, but there are a lot of similarities between the two specialties, and I know lots of trainees do apply for both. I certainly applied for both when I was applying, and would have happily taken up a clinical oncology post if that was all that I'd been offered. So I think both are very rewarding and very interesting careers. What do I think of the attractions of medical oncology? Well, for me, the main thing is just how many new treatments are coming through, and this is increasing all the time. So you can do a tumour site once early in your training, and then 2 or 3 years later, and it's all changed. And again, some of our colleagues may sort of slightly dispute this, but generally, most of the new treatments coming through will be delivered by us. And this is just to illustrate some of the sort of explosion in treatment. So this is for lung cancer, a timeline of all the new drugs that have been approved, and you can see from 2003 to 2011 you got 1 or 2, and then in the last few years there's just been an explosion of targeted therapies, and this is all of the new drugs approved in lung cancer. And again, you can see for a long time not very much change, and suddenly there's just a huge explosion in number of treatments, and this is really exciting for us, but it does make it challenging. And I think this is going to be mean that during our careers things are going to change even more. There's lots of scope for research, clinical trials, and Ben will talk a little bit later about research. And And you also, I think there's a lot of variety in the type of patients you look after. So you get people right at the beginning of their cancer journey having curative treatment before their surgery. And then you get patients right at the end of their cancer journey where you're looking after their symptoms, potentially giving them some treatment to try and help them live longer, but also living well. And there is a lot of overlap with palliative care, unfortunately, or fortunately, depending on what you want from your career. Lots of multidisciplinary working. And this was a slide from one of my colleagues, Dr. Ella Daniels, who did this talk last year. Again, just showing some of the things that are appealing. You do get to know patients over quite a long period of time. So that's really rewarding, seeing them go through different stages. There's increasingly a focus on acute oncology. So if you do have an interest in acute medicine, there is some overlap there. What does a medical oncology SPR do? I've just written a few things here, so I'm not going to go through these in huge amounts of details, but essentially it's predominantly an outpatient specialty. So a lot of your time is spent in clinic, seeing new patients, reviewing patients on treatment, going ahead with their treatment, prescribing it, and then also then managing the complications of their treatment. And if anyone's done an oncology job, you realize that that's becoming an increasing part of our workload, particularly immunotherapy. We also manage complications of the cancer, so symptom control and managing the oncology emergencies. You do also look at, sort of often review patients who get admitted who haven't got a diagnosis of cancer but come in as an emergency with complications. And there is a lot of work on clinical trials. In terms of non-clinical stuff, this is all very generic, but these are all the things that you do get to do on a sort of day-to-day basis. Some people do research, although not everyone does. We've just run a survey of UK trainees, and about half of people don't have any research degrees. So it's not a prerequisite for doing medical oncology. But if you do want to do it, there's plenty of scope for it. Lots of meetings, conferences, teaching, and some of the sort of more generic things. Lots of people do out-of-program experiences. So this is just some time out of training to improve your experience. So for some people, that's to do a PhD, but there's lots of other things. So lots of people do leadership. We've had a number of medical oncologists who have gone through the Chief Registrars program and really got a valuable experience from that. People that do education, and then there's also lots of scope for doing fellowships, both in the UK and abroad. As the chair of the ACP trainee committee, I have to shamelessly plug our website. So the address is there. We do have some information for applications, although hoping that will be more comprehensive soon. But it's certainly worth having a look at some of the resources we have there. In terms of tips for applications, so in terms of commitment to specialty, if you are, as Simon said, it really isn't definitely, you don't have to have done oncology as a junior doctor, a resident doctor. So even going back to medical school, there's things you can do. So there's a National Society bonus who do some really good work for people that are interested in oncology. So it's worth checking out their website. They have a yearly conference, some study days, and an essay competition. Obviously, you can choose to do an SSC or an elective. And then when you're in your sort of resident doctor jobs, if you can, when you're applying for your internal medical training, if you know you're interested, it's worth trying to rank highly a job that has oncology in it, just so that you know that it's the right thing for you, that you enjoy it, and it does also give you an opportunity to do some extra projects. But it certainly, don't worry too much if you can't. There are other ways that you can demonstrate your commitment. And I think if you don't have a job in oncology, anything that you do is hopefully going to demonstrate your commitment. Sort of just having a job in itself isn't enough to say that you're really committed to the specialty. Taster days, I know that sometimes that's not easy to organise. Somebody put that in the chat. If you have any problems, you can contact one of our regional reps to help. But I think whatever specialty you do, whatever rotations you do in your resident doctor time, you will always see patients with cancer. They will present to every specialty at some point. So there's always something that you can do to demonstrate. So I know somebody who was interested and when they were on their orthopedics rotation, did an audit of pathological fractures that presented to the orthopedic department. So, although it was in their day-to-day practice in orthopedics, it was something that was cancer related that they could put on their application, say I'm committed to oncology, and that they did very well in their applications. So whatever specialties you do, there is always something you can do oncology related. So projects, courses, conferences, there are some resources that the ACP itself is running. We do have a webinar series that you can log into. And then the other organisation that would be useful is, some of you may have heard of, is Notch, so the National Oncology Trainees Collaborative. They, again, run an annual conference and also have some projects that are ongoing, which you can try and get involved in. I would suggest you try and get your MRCP done as soon as you can. 2 reasons. One, it scores you extra points at the time of your application, but it also means that you're not in a hurry to try and finish it by the time you get your training post. And it also allows you a bit more time in your internal medical training to do other things like audit quips and things. Tips for interviews. There's lots of guidelines available for how you manage acute problems, acute complications of chemotherapy and there's the National Institute of Health Research have something called Good Clinical Practice, which is essentially the guidelines for how you should conduct research. So it's worth logging in and doing the training for that. It's free. Anyone can do it if you have an NHS email address, and it's something that would be good to just demonstrate your commitment, but also underpins how we perform research. That'd be useful to know. It goes without saying, if you put something in your portfolio or in your application, make sure you're completely familiar with it, because it's something that you might be asked about. Anything you present in your application could be asked about and discussed in the interview. And I think just trying to get a practice interview, I was fortunate there were some really good med and clin-onc consultants in Leeds that gave us some really valuable feedback from practice interviews, and that really helped. So the take-home message, I think there's different ways to get into training. Each person's unique and there's no right way. I really think if you don't succeed at first and you really want to do it, just take it as an opportunity to get a bit more experience, and that will actually help and make you, I think, better prepared to start your training. There is lots of chances to do research, and Ben will talk a little bit more about that, but it's certainly not compulsory. And many trainees are less than full-time, so don't be put off if you are less than full-time. So with that, I will hand over to my colleague Ben Pickle-Smith, who's got a lovely picture of himself on his opening slide.
Thanks, Richard. Sorry, I maybe didn't need that photo. Anyway, it's a reminder of what I look like. Next slide, please. So something that we get asked a lot is about that question of, do you need a research background to apply to medical oncology, and do you need a research background to get ultimately get a consultant job? And the answer is no. I think this stems a lot from how medical oncology was developed many years ago. And it is associated with research, and it is a research heavy specialty, but it is not mandatory to enter a training pathway that you've got any sort of background in research. And as I say, you don't need it to CCT or become a consultant. Now, it might make you more competitive, and certainly there are some centres with maybe a higher proportion of consultants with PhDs, but more and more across the land are people that are research active but without PhDs. We are expected to contribute, though, to cancer research and be actively involved in trials. So I've taken this from slides presented last year, but this is from the curriculum. These are I've written this down, this acronym, our capabilities in practice, or our SIPs. And so we are expected to be able to implement clinical trials of systemic anti-cancer treatments at investigator level. And that's actually really nice and fulfilling part of the job, taking part in recruiting or identifying eligible patients, recruiting them and managing them throughout their journey. Next slide, please. So what is my background? What's my pathway? I started off many years ago, graduating from the University of Kiel. I did not have an intercalated degree. I didn't do any other any other. I didn't do anything oncology related as part of the medical societies. Next slide. I then went to Oxford for my foundation. You'll notice I didn't take part in any academic foundation program. I didn't do any oncology at that point. Next slide. Next thing. And then I moved to Leeds, and that was partly because my family are here, up near here, and I thought I spent a long time away from home. So there was no academic component to this job. Now, I did do oncology, and I remember saying to people at the time, why would I do oncology when I'm doing cardiology, renal, you know, the exciting medical specialties? But it was on day one of doing oncology, really, that it's very cliche, but I fell in love with the department, the patients, the support. I just absolutely found it fascinating. Next picture. However, I wasn't successful first time round in applying to where I wanted to be, which is in Leeds. I did, however, get a training number at the Christie, and so I took up ST3 at the Christie, and again, no academic component. But I really wanted to be back over here. So I went back through national recruitment, and I remember the interviewer saying, why do you want to be a medical oncologist? And I said, well, I am one, but I just want a better score to be in the place where I want to be. So I did get a better score, and I was successful in transferring my number. I didn't need to move back to ST3. I was able to transfer at the level that I was over in Manchester. So in the West Yorkshire Deanery, there's multiple different cities that we rotate through, which is, I think, is a real strength of medical oncology training, in that there are medical oncologists in district generals, and that isn't necessarily true always of clinical oncology training. And so in West Yorkshire, you rotate, yes, through Leeds, but also through our district generals. And that's a lovely picture of York. All these pictures are nice, shiny, happy days, aren't they? So that's York, where I've spent some time. And then it was halfway through ST4, beginning of ST5, through chats with colleagues that were on academic pathways, I thought, oh, I really would like to get involved in academia. And so I was really lucky getting a Yorkshire Cancer Research funded PhD, which I started and completed at Hull York Medical School, pictured there. And this really was my first foray into academia. Final picture, please, Richard. And then coming out of the PhD, I've come back into clinical practice, clinical training at ST5 and ST6, but now as a clinical lecturer. So now I'm on a formal academic pathway. So 50% of my week I'm conducting research at the University of Leeds, and the other 50% I'm being a training registrar. Next slide. So as you can see here, this is your standard, if you click through a few, Richard, this is your standard NIHR, which is one of the major research funders. This is their standard schema of what academic training looks like. So I didn't, in medical school, didn't get an MB or a PhD. I didn't do academic foundation. I didn't do initially academic fellowship in specialist training, although I am now a clinical lecturer. What comes next, I would hope to apply. Well, I'm applying for an advanced fellowship, but it remains to be seen if I'm successful or not. But I have certainly gained a lot from these few years in research. But what I wanted to emphasise is you do not need an academic pathway to be successful. Next slide, Richard. So careers in clinical academia can take many routes. Some of you may be aware of the integrated academic training, which you can enter from FY1. I believe you can enter it at ACF level, and then you can also enter it later on, like me, as a clinical lectureship. But there are other routes to gain academic expertise and expert training. So, for example, I put up here the CRUK Clinical Trial Fellowship Award, which we've got a few people in Leeds that have been through this, and there are many others as well. These are just two that came to mind. Next slide, Richard. So in terms of my career highlights, this was a presentation I did of my research, and I got a prize for that, which was really nice. Next slide. Some of my research has taken me on a funded trip to New York, which was really cool. Next one. I was on the steering committee for the National Germ Cell Cancer Conference. So I was able to chair sessions, and I developed the agenda, and I gave speeches. Next one. I've presented posters across Europe and the UK. Next one. Yeah, this was in Madrid. That was really cool. And then a real career highlight for me was getting my PhD in there last year. Next slide. Now, there's some questions about work-life balance. And we do have a really good work-life balance, I think, in medical oncology. First one, throughout my training, I was easily able to organise a wedding, which, as some of you may know, it takes an awful lot of organisation. That's a picture of me running a marathon last year. Next one, I've partook in a couple of triathlons, and again, these are all time-consuming activities that I've been able to do out of work. That's a bunch of us oncologists. This maybe isn't work-life balance. This is a group of us that do parkrun every week, and we all work together. We're all really good friends. Next one, got a dog, and the final one is I'm part of a book club through work, actually. So I think I do have a good work-life balance, and I think most of my colleagues do. Next one. So what's a typical timetable for us look like? It's a bit different now that I'm on the academic track, but going on the academic track, this was when I was on sarcoma and teenage and young adult rotation. But on a Monday morning, I had a clinic over the other side of the city in Leeds with the paediatricians. And that's a really nice aspect of the medical oncology training. There are tumour sites that you have to do, and then there's some flexibility with other tumour sites like this. It's only because I'm interested that I kind of pushed for this, and they've been able to facilitate this. Monday afternoon was the paediatric grand round where they discussed interesting cases. Tuesday mornings we had a ward round of all of our patients with melanoma, germ cell, tumours, sarcomas, and teenage and young adults. Tuesday afternoon was admin. Wednesday morning was a germ cell clinic, and in the afternoon it's meetings, audits, M&M, morbidity, mortality meetings. On a Thursday, again over at the other side of the city, I would help with the paediatric ward round, and then there were 2 MDTs. And then Fridays for me was ward round and germ cell MDT. There's a few questions about on call I saw in the chat and in the pre webinar questions. On calls vary depending on where you are. When I worked at the Christie, they've now moved to a resident night shift model. Here in Leeds, we do non-resident night shifts, but resident weekends and resident evenings up until 9 o'clock. Now, I can't work out exactly how many weekends. I think it's roughly a weekend every 6 weeks, but again, that varies a bit depending on how many people are on the rota. And you do at acute oncology on-call SPR of the week. Next slide. What's my timetable look like now? I have 2.5 days a week are academic, so I will not bore you with what I do then. But Tuesday mornings, I'm on the urology med-onc clinic. Wednesdays, I've got a urology med-onc clinic, so seeing prostate, bladder, kidney cancers and penile cancers. And then we run a toxicity clinic in the afternoon. So we have now we're using lots of immunotherapy. We have patients with that can be outpatients, but have toxicities that need managing. And then Fridays, a ward round, and that says admin, and a kidney or prostate or bladder MDT in the afternoon. Next slide, please. There's lots of questions we get about interview tips. I can't say it enough. Practice, practice, practice. Practice with your mum, your dad, your partner, friends, colleagues. Other specialties. I've helped a number of my friends who are applying for high specialty training, and you can give a different perspective that's really useful. If you can, do some practice with oncologists, clinical or medical, but just practice, practice, practice. I honestly cannot emphasize enough. I'm not obviously going to share questions that I got asked, but you can predict some of the questions, so just think through how you might ask them. And it's always alarming. You know what you're going to get asked, and then when someone asks you, it's a bit of a shock. So just practice. Think broadly how you answer them, but don't be robotic. Don't have it on a script. Don't rote learn it. Just think broadly, and please be enthusiastic. The number of people I've interviewed that weren't. Allow yourself a 5-second chance to pause. It will feel like a lifetime to you, but it does get your thoughts in order, and it really does help. It's not a lifetime to your interviewers, but 5 seconds might just be enough. Be familiar with NIHR good clinical practice. You don't need an in-depth knowledge, but just have an awareness of this, and please be familiar with your portfolio. There are some resources out there. I've got no vested interest with this book at all, but I've used this book for core medical training. Now it's IMT, and both sets of interviews I did it's quite helpful for me anyway. Next slide. In terms of educational opportunities as a medical oncology registrar, I learn something every single day, and I think there's so much to be said for learning on the job, and it's a real privilege job, I think, and we're very lucky everywhere I've worked to have amazing mentors and supervisors and consultants from clinical and medical oncology. So you will learn so much every day on the job. But there are more formal educational opportunities, such as regional and supra-regional teaching days. And often departments will run a journal club, which is fantastic. There are courses around. So the Christie run the biological basis of cancer. So when I was in that deanery, I did that, but I think people can apply to go and do that. In Leeds, we do run a biological basis of cancer course that runs for ST3. There are various different tumour study specific days in the big cancer hospitals. ESMO preceptorships are wonderful, and if you remember one thing from this, and if you are lucky to get a number, remember ESMO preceptorships. So ESMOs are European Society of Medical Oncology, and this is, again, sounds very cliche, but it's kind of European family of oncologists, and they run these 2-day crash courses in different tumour sites. So I'm off to Lugano, I think it's in Switzerland, in September, and I've been around Spain and Germany on these preceptorships. They're mostly funded. They're almost fully funded. You do have to pay some things. The ACP webinars are an amazing series of webinars every month covering different topics. There's a UK Oncology Forum, which happens once a year. This is the UK's only pan-cancer, pan-specialty conference, and we cover updates from ESMO and ASCO there. There are very good industry events as well, local and national, and that there are many conferences, tumour site-specific conferences, such as the Germ Cell Conference I went to, ESMO and ASCO. Next slide, please, Richard. Oh, this is my final slide. Good luck. It really is an amazing career. I cannot rate it more highly. I've never looked back. Thank you very much. I'm happy to take any questions.
Yeah, thank you, Ben. So I think we've been answering questions through the chat. So I think we'll move on to our final talk then, if that's all right. So I'd like to introduce again Dr. Satinder Jagdev, who is another Yorkshire Leeds consultant, who will talk to us about a consultant perspective. So obviously the whole point of going through a training program is so that at the end we become a consultant. So it's great to have Satinder here to talk about what being a consultant in oncology is like, in medical oncology.
Thanks very much, Richard. So I am going to turn off my video just so that the audio comes across a bit more clearly. There we go. Right. Thank you. So yes, I'm a medical oncologist in Leeds, and I just really briefly, just to give you a bit of a flavour about what life is like as a medical oncologist, and certainly the types of things that you can get involved in medical oncology across your career. So suffice to say, it's very varied and very interesting. So these are just a few of the points that I brought up, which again you can see have really been echoed by Richard and by Ben in their talk. So why did I go for medical oncology? So you really get a holistic view of the whole patient journey. So we treat patients in curative settings all the way to the palliative setting, and actually I think it's one of the few specialties where you get some continuity with the patients, and you can really follow them through their journey, and you also have a coordinating role. And it's obviously complex. There's lots to get your teeth into in terms of the clinical work, and as we've heard already, it's really a very fast-paced, fast-moving specialty in terms of the research coming through and bringing new systemic treatments from the labs and from the bringing the science really through to the bedside and changing the treatments that we are able to give to our patients. And it's a great specialty to work in terms of colleagues, and we do work very closely with our clinical oncology colleagues, but also the radiologists, the surgeons, the pathologists, so it really is a team approach, and there's lots of opportunity for career development, which I'll talk about in a minute. We've heard about some of the networks through Ben's talk just there, and there are many organisations that you can get in touch with, and also regional networks as well. And again, in terms of the work-life balance, I would also attest to that. I also work less than full time, and have a family and interests that I follow. And so I think for that it is a really good specialty. Yeah. Moving on. Thank you. So what do I do as the core of my job? So we work in an MDT setting, as I've just explained, with other specialists looking at reviewing new diagnoses and individual cases. We formulate management plans, which will then take the patient, to other clinics or into our clinic. And as Richard had said, really, the bulk of the work is in the outpatient clinic. And as IMT residents, as foundation residents, it's really important that you get yourself down to clinic whenever you can to see the other side of it, because it's easy to think that it's a depressing specialty, or that patients are often very ill, but actually there's a really the counter side to that is seeing the patients that are doing really well on treatment and are living their lives. So the part of that again is doing ward rounds and seeing the inpatients. And many of us are part of the on-call rota and also acute oncology as well. And again, there's plenty of scope to bring your general medicine into the job, because certainly you'll see the medical complications of cancer, but also acute medical problems in cancer patients. They just happen to be, a patient with cancer. And I'm very heavily involved with education and training. I have also research is a big part of my job as well, in terms of clinical trials, and so it was really very varied on a week-to-week basis. Thank you. Next slide. So thinking about where you can go and what you can do, really, there are multiple options, and we've heard about a couple of those through Richard and Ben in terms of the academic pathway, but also other things that you can get involved in. And really, the majority of us will have some role outside of our core NHS clinical work. So that might be academia, that might be education and training, that might be clinical management. So many people will follow a clinical management route. Some of us will work for external organisations, such as the College of Physicians and other organisations, in terms of strategic work. And in terms of the settings that we work in, there is the option to work in a cancer unit where we're based in the District General, or a cancer centre. Thank you. Next slide. So at the end of this, I mean, we have been expanding oncology's resident specialty training posts, and certainly the question is, will there be a job for me at the end of this training that I'm applying for? And I guess the thing to say is that we have the complexities of an aging population. There are improving. We want to improve cancer outcomes and access to treatment. As you've seen from Richard's slide, there's an exponential increase in the systemic therapy options for all different, all of the different tumor types. And so we really need consultants to be able to be trained in delivery so that our patients can access the best treatments possible. Acute oncology services take the burden of the acute work from the general medic, so that again is an expanding specialty, and the type of job that you'll have really, will depend on the priorities of the regional service that you're applying for. But there is scope to include some of the other aspects that we've just talked about. Next slide. So I just included this just as a general. This is my last slide. Just to really, when you're thinking through what is it that I want to do, which is the career that is going to suit me, I think there are some key questions really to ask yourself. What do I enjoy? What is it that you enjoy? If you enjoy kind of a fast-paced specialty, certainly oncology, both clinical and medical oncology, would be good options. And the kind of medical side of the systemic therapy certainly is fascinating. What are my strengths? To do oncology, really, you have to be willing to really develop your communication skills, deal with difficult situations, think about complex clinical problems. So where do your strengths lie? Really important to have a think about that. I've included there, who are my people? So I think it is important that you make contact with your local medical and clinical oncologists when you can, and try and spend some time if you're not able to do a job in oncology, because actually it's really important in any specialty, to look around at the consultants and the senior clinicians and think, well, are these people that I could work with? Is this an ethos that I can, settle into? And, does this feel like the right thing to me? Are there people that model the kind of things that I would want to do for myself? And then again, how can I get a taster? So just, as the previous speaker said, don't be shy in getting in touch with the oncologists. We're always happy to welcome people down to our clinics, for people to come and to see what we do. We're very enthusiastic, as you can tell, about our specialty. So, even if it's not a taste a week, perhaps a morning or an afternoon, anywhere where you can squeeze in a bit of time to really see the outpatient side of oncology, I think, is important. Next slide. So this is my final slide, because I think it's important we get onto your questions. So I would say go talk to your local friendly oncologist, and all the very best of luck with your applications. Thanks, Richard.
Brilliant. Thanks for that, Satinder. So whilst we do a Q&A, on the background here is just some useful contacts. So some useful websites, and also some contacts, so for all of the people that have talked this evening. And then there's a list here of all of our sort of trainee committee regional representatives. So if you're interested in training in one of these areas, you can contact one of these people. As you can see, we don't have, unfortunately, quite yet full coverage of the UK. So there are some deaneries that we don't have represented, and I'm trying to work on that. But if you want to find out anything about any of the other deaneries, feel free to contact me, and I can try and put you in touch with somebody, or if you know somebody locally. So I think we've been trying to answer some of the questions as we go through. So I think, Ben, there's been some questions about working between med and clinic. So I don't know if you want to just expand on that. I know you've just written a fairly lengthy reply, but I wonder if you just want to expand that. And then obviously our colleagues from clinical oncology, feel free to contribute to this question, because it's really important that we get your viewpoint as well.
Yeah, I think that would be really good to hear our clinical oncologist view. But we enjoy such a close working relationship with our clinical oncology colleagues. It's they're just incredibly responsive wherever I've worked. And it depends. It depends what you enjoy and what you like. I enjoy the complex therapies, and I find it a real privilege looking after people on more palliative treatments as well. So yeah, it depends on what you enjoy. I think there are some cancer sites which are more geared towards medical oncology rather than clinical oncology, and vice versa. So for example, head and neck, CNS tumors, and radical treatments of early esophagogastric and cancers, etc., are really well geared towards clinical oncologists, whereas looking after someone with ovarian cancer on sixth line treatment, for example, and our germ cell tumors, generally that's generally what we would look after. Obviously, yeah. So I enjoy medical oncology. But let's move on to the clinical. David had his hand up first.
Yeah, thanks very much. I guess just to add, I completely agree with what you said. I think people are often quick to think of what's the differences between us, but I think the first and most important thing is to be interested in oncology. I think getting involved with taster week so you yourself can see, the differences in which you may like. Yeah, I guess for me, having radiotherapy or doing radiotherapy is sort of one of the key differences, but given that I do it. But yeah, I think being involved and interested in oncology is the most important start, and then maybe exploring, talking to local people, and getting a feel for what a taster week is like. So yeah, I agree with what you said. Thank you,
Louise.
Thank you very much. Yeah, so I agree with everything that's been said, really. And I think there is a lot in common between the two specialties. We're both very patient focused. We all treat patients with a variety of cancers. We use cutting edge treatments, very research focused, although, as you said, research academia background is not absolutely essential. In terms of radiotherapy, so we often work kind of hand in hand with our medical oncology colleagues within MDT meetings. And obviously, as David said, we do train in radiotherapy. So that's, a key part of our training. So we are able to treat patients sort of throughout their cancer journey, if you like. We plan their radiotherapy, and if they're having systemic anti-cancer therapy kind of alongside that, we're able to do that. And referrals to radiotherapy are really easy. Just speak to your clinical oncologist in your department, and it's all done. We work very closely within site-specific teams.
Thank you. Yeah, and it might be easy for us to refer. I don't know how easy it is for you, but the clinical oncologists that we work with are very expedient and are so responsive, and I don't think there's any detriment to them seeing us first, because things happen so quickly that I'm not sure what goes on, Louise, but Simon.
Thanks. Hopefully, I think we've covered that question. I was just quickly going to suggest to Richard, obviously we've got Louise and David with us. We're probably a little bit short of time, so we'll go through the Q&A, but it was a reminder. We know that a lot of you out there are still deciding between specialities, and we want people to be oncologists, and there's two different flavors. There is the RCR webinar that was run recently. Is also available, and I think Louise or David, I don't know if you had any broad comments about the recruitment process that I ran through. It's very similar between the two specialities. Our offers come out at the same time, but if there was any differences you wanted to highlight, it's probably a good time while we get our head around the rest of the questions in the chat, if that's okay.
I'm happy to take that one. Thank you. So yes, as you said, the recruitment process is run in parallel, because we are very mindful that some candidates apply for both specialties, and so the offers go out at the same time. The process is very similar. Do look on the website. There's a lot on the Royal College of Radiologists, that's the RCR website, about a career in clinical oncology, and our webinar that we held 2 weeks ago is also on that website there. In terms of the process, it is very similar. It's a matter of submitting evidence. The evidence is slightly different for the two specialties, so do make sure you read the spec. And then there's an interview process, which is a combination of clinical, ethical or professional, and then portfolio-based questions. It's 30 minutes and you have 3 stations. I don't know if you want to say anything more about that, David, as a specialty registrar, whether you've got any more to say about the process.
Not necessarily overly. I mean, from personal experience, I absolutely wasn't sure necessarily at the time of applying which I wanted, and applied to both, and then had to try and make the decision afterwards. But that sort of preparing felt reasonably similar. There's going to be reasonably similar things you're asked at interview, and yeah, no, absolutely.
We've had a couple of questions which are all along a similar theme of the sort of end of oncology combined STEM, so end of ST3, switching between the two specialties. So I'm happy to pick that up, but obviously can have input from others as well. So essentially, as I understand things, so our first year is we have essentially meant to be the same training. There will be some slight differences. The clinical oncologists have to prepare for their first exam, which is at the end of their ST3 year. But as far as I understand it, at the end of ST3, if you want to switch to the other one, you still have to go through the recruitment process. So you would have to go through the evidence, submitting your applications, evidencing it, going through the interview stage, and you would be in a national competition. And if you score highly enough, you might then be offered a place in the other specialty. But it is still through national selection. Now, clearly, if you've done a year's worth of oncology training, you would like to think you're in a strong position to be able to change. So I know that there have been some people in Leeds who have gone both directions, one from medonc to clin-onc and one from clin-onc to medonc. So it is possible. It's not as straightforward as saying, oh, I fancy doing the other one, I'd like to switch. You do have to go through the selection process, and it does depend on there being places for you to rotate training posts to go into. Hopefully that answers it. And does anyone have anything else, sort of any points of fact or anything they'd like to add to that?
So just to add, it's Satinder here, Richard, what you would have to do if you were looking to reapply at the end of ST3 is that clearly you'd have to keep on top of your portfolio and your assessments and all of that, because to be able to transfer, you will need to be on an ARCP outcome 1, and the ARCPs will often happen after the application and interview process if you're going through that. In ST3. Clearly, for some people, they will get to the end of ST3 and then decide, later on. But I guess if it's something that a resident has thought about fairly early on, then actually making sure that their portfolio is really kind of is going to get them through, and they're gaining all their competencies is really important. And as has been said already, you would then apply through national recruitment, that competitive process.
Good. And there was one other question that came up in the chat that I think we can address. Somebody who asked about PACES. So somebody asked, if we apply and get an offer but did not manage to complete PACES by the deadline, would this be marked in the next round of applications? So I perhaps hand that over to Simon.
Yeah, thanks, Richard. I think the short answer is yes, you'd score more marks for your MRCP in the next round of applications. There isn't a sort of memory or a carryover. You'd have to do another application, but you would clearly score more because, as you mentioned, MRCP is one of the biggest scoring components of the evidence and the verification.
I think the question was more, so you wouldn't be penalised on a future, if you.
Oh no, I mean,
yeah.
as you've been, as you've said, some of us get to the privilege of interviewing more than once. No, come back. You wouldn't be marked down. It's more a case of get higher marks in the next time round.
But unfortunately, if you didn't have paces, you wouldn't be able to take up your training post.
Correct, and occasionally, obviously, that does happen because the point is you have to have the membership by the time you start the post, and the long listing will look at when the diets of the MRCP are and when you can attain that. But unfortunately, some people will be in that position, and we're all aware that's just life and professional exams.
So I think we've managed to answer most of the questions throughout as we've been going through the chat. So unless there are any last minute questions, I think we could probably draw it to an end. What we will do is when you finish, there will be a link to a survey, a very short survey. There's 3 questions, just to make sure that this was valuable for people. And as part of that, there is a section where you can free text any questions. So in the next few days, we'll have a look at that. And if there are any sort of questions you didn't ask today, or you wanted to ask privately, just put those in the survey response, and we'll try and get back to you. Clearly, there's lots of contact details there as well. So if you've got any questions, you can ask anyone on that list. But otherwise, I think I'd just like to thank all of our speakers and thank you all for attending tonight, and hopefully see some of you as future colleagues.